Um, No. Okay, and we are sharing.
Recorded. Release.
Okay, does everything look good, Elaine?
Yes.
Okay, great. I did it. Good morning, everyone. Welcome to Coplow Rounds. I am Kelsey Brown. I am one of the staff pathologists here, and I'll be taking us through the first two cases. So we'll go ahead and get started. No. Hopefully that'll move. Okay, so first case, I have some clinical photos. The clinical team was nice enough to give us kind of a progression of this dog's eye. So this is a 14-year-old male castrated Chihuahua. And the history we received is that approximately 3 months before enucleation, this dog was diagnosed with complete hyphema in the right eye, which is the eye depicted in these photos. As that hyphema began to resolve, the dog was diagnosed with a mature cataract. And the month of enucleation, they diagnosed the dog with keratoconjunctivitis sicca, glaucoma, as well as a superficial ulcer. So this is probably around that time. You can maybe see the outline of that ulcer here. They discussed medical management. It sounds like they tried that initially, but the corneal ulcer worsened. It became larger. And it seemed like there was a bit of a cellular infiltrate associated with it. They also, at that point, diagnosed hypopyon in the ventral anterior chamber, which we can see here. And it sounds like the eye at that point was blind, it was ophthalmic, and they elected to enucleate. The clinical team also gave us some questions, some specific questions, which we always appreciate. So they wondered if there's any other reason for the hyphema beyond just maybe a mature cataract and uveitis. They questioned if there was maybe neoplasia within this eye. They're also concerned about the corneal ulcer being infected and wondered if we would be able to see any microorganisms. Some other things about this dog. It does have a 4 out of 6 heart murmur, as well as right forebrain changes on neuroexam, which may or may not be relevant to this case. I don't have a gross photo of this eye, but I have our gross notes. We did say the eye was ophthalmic. We were able to appreciate the large axial ulcer, as you can see here. We said the lens did look cataractous and the vitreous was liquefied, so there's evidence of vitreal degeneration. Right. So we will go on. That one. And I will, at low power, kind of do a tour of this eye. What's up?
Oh.
Zoom?
I hope we did not share did we share the entire screen?
I thought I did, maybe not. Hold up.
Oh, you just did.
Sure didn't. All right, how's that look now?
Yeah.
Okay, great. I always mess up one thing when I'm setting up, so that was a pretty benign one. Okay, so low power, we'll do a tour of this eye. There's a little section, we call this the gonio section, just lets us look at additional angles. We're going to ignore that. We have our cornea here to the right. Our posterior segment will be to the left. And from here, we can see there's an ulcer. So here's our corneal epithelium. And as we approach kind of the paraxial to axial cornea, it becomes discontinuous. So there's this area where it's just stroma that's exposed. We can see from here, maybe there's kind of these blue dip dots. So there's evidence of some sort of infiltrate within the stroma. As we move into the anterior chamber, there is a bit of an exudate likely corresponding to that hypopyon diagnosed clinically. So we can just see there's probably some cells here. There's this eosinophilic material. You can look at that more closely. Here is one of our iris leaflets. It's also just a little bit more blue looking in the stroma, so likely there's also a cellular infiltrate there. There is our lens. There is certainly a cataract. Here's our lens capsule. We can see there's kind of this undulation to it. And there's just kind of a difference in the properties of the lens fiber. So here they just look a little bit more pale and amorphous. And over here, there's also some mineral in here. So at low power, we definitely have evidence of a cataract. And as we move back, there is some kind of artifact here. So ignore these little black splotches. But here's our retina. It is detached. Same over here. And overlying the central retina, kind of extending into the vitreous, there's this blob, for lack of a better word. There's some erythrocytes, so these areas with red, so evidence of hemorrhage. There's some yellow, some brown pigment, so likely some blood breakdown products. Likely this hemorrhage has been here for a second, which does kind of match the history. 3 months prior to nucleation, there was hemorrhage in this eye. There's also these clear spaces within this blob of tissue, and we'll look at that a little more closely. And then here is our optic nerve head. It does look like some areas there's a little bit of pallor. It is distorted by the detached retina as well, so it kind of causes it to get stretched out and a little bit messed up looking. So first we are going to start by looking at this corneal ulcer. Focus, there we go. Ooh, always fun. So let me actually move away from the exciting part really quick. There is indeed a cellular infiltrant here. So we have some neutrophils, so a bit of a neutrophilic keratitis. But more excitingly, there are organisms in this cornea, as clinically suspected as well. Go one closer. So these are fungal organisms. The majority of them, I feel like this isn't very good. We'll go back to 40, are going to be fungal hyphae. So we can see these hyphal organisms. They have roughly parallel walls, pretty sparse septation. So here are some septa, and they are branching. So a lot of them are doing this 90-degree angle branching. I feel like there's a really pretty one in here. It's maybe, there it is. Very cute little branch coming off of this one. In the more anterior stroma, there's also these little round organisms, which potentially some of these are just cross sections through the hyphae, so we're just seeing them end on. It's possible maybe there's also a yeast form in here too, but majority of these are pretty distinct fungal hyphae. And as we move into the deep stroma, we can see those hyphae continue even into Descemet's membrane, which they love the glycoproteins that are present in Descemet's membrane. So this is a great place to look if you're suspecting a mycotic keratitis, like in this case. It's pretty obvious here, though, so they kind of jump out at you. And as we move into the anterior chamber, there's a lot of fibrin in here, so this eosinophilic kind of fibrillar material. There are some neutrophils as well, so we have this fibrinosuppurative exudate. And there are also some fungal hyphae in here as well, which is kind of interesting. I did do special stains to better visualize kind of the extent of these fungal hyphae, and they aren't just confined to the cornea and then to the very, very anterior aspect of the anterior chamber here. So I do wonder if this is just an opportunistic infection of the ulcerated cornea. I don't know how often I've seen them extend into the anterior chamber, so that was kind of a weird little finding. But
Trying to be a horse.
trying to be a horse. So we do have a mycotic keratitis, which does provide an explanation for why that ulcer would not heal despite medical management. As we move over to our iris, and look at that infiltrate. It's really just mostly lymphocytes and plasma cells. It's kind of a high contrast. So there is a uveitis, which we have good reason for that. We have a mycotic keratitis. We also have a pretty decent cataract. So this could be a reflex uveitis or a lens-induced uveitis. Right on top, so there's some distortion of the iris here, but if you can imagine with me, on the interior border of the iris, there is a fibrovascular membrane. You kind of see a vessel here. And if we can kind of imagine, it does extend over across the iridocorneal angle, causing this peripheral anterior synechia. So we have good reasons for glaucoma in this eye as well, likely a secondary glaucoma. Here is our cataract. Just kind of quickly show that. It has a couple of the hallmark changes we see with the cataract. So this is the anterior aspect of the lens. Here's our lens epithelium. And if we travel to the posterior lens, we can see that that epithelium continues. So there is posterior migration of the lens epithelium, which is kind of one of our first changes we see with cataractus degeneration. If we actually look at the lens fibers, so here we kind of have more normal-ish arrangement of the lens fibers, and over here we lose that lamellar arrangement. It's kind of just this liquefied lens protein. We can even see these purple little dip dots, so there's some mineralization in here as well. Pretty decent cataract. And as we move back to our retina, this is a true detachment. In some cases, we do see artifactual detachments just during trimming or processing. But in this case, we do have evidence that this is real. One being that we do have an outer atrophy of the retina. So here's our outer nuclear layer, and the nuclei are just a little bit more sparse. And we also have loss of the photoreceptors, or what we call the frilly frills, very scientific term. And if we look at the retinal pigment epithelium, there's areas where they're variably hypertrophy, which is a change we see with a true artifactual or true detachment, non-artifactual detachment. And then we'll look at this blob. There we go. So there's kind of just this loose eosinophilic tissue, and embedded within that, there's all of these small caliber vessels. That's what all those clear spaces were. Here's another vessel. And then interspersed with that, there are some erythrocytes, so evidence of hemorrhage. We have some hematoidin pigment, so this bright yellow pigment, and some hemosiderin pigment, which is this more golden brown, oftentimes within the cytoplasm of macrophages. So we have macrophages that came in and just gobbled up and broke down this pigment. So this finding here, coupled with the hemorrhage and the retinal detachment, does make me wonder about this dog's systemic blood pressure. These can be changes that we see with systemic hypertension, and that would prompt one to look at vessels very closely, which stare at some of these. In the kind of peripapillary tissue, so right next to our optic nerve head and optic nerve, we do have these smaller caliber arterioles, which are a little bit suspicious looking. They're a little bit thick. We have these hypertrophied myocytes in the tunica media, and then maybe a little bit of matrix deposition of the subintimal space. Here's our internal elastic lamina, and there's just kind of this material that's there where it should not be. And yeah, every so often, just kind of we've lost the defined layers of our vessels. And in our choroid, every so often, there's, again, just kind of these suspicious vessels here and there. I did equivocate a little bit with this one, but I strongly recommended that they checked the systemic blood pressure of this dog if they hadn't already, because I wonder if that could have been the cause of the hyphema in this eye originally. And I guess the story that I would like to tell is maybe if this dog did have systemic hypertension, we had retinal detachment, this fibrovascular membrane formation on the iris. That's a great cause for fibrovascular membrane formation. Secondary glaucoma, and then maybe this ulcer eventually formed and got infected, causing mycotic keratitis. So kind of just a good constellation of lesions in this eye. I didn't have any follow-up though, so I'm not quite sure if this dog truly did have systemic hypertension, but it does look very, very suggestive. All right, so here are my diagnoses for this case. A little bit abridged. I had quite a few in here. Biggest ones being mycotic keratitis, and then our retinal detachment with this kind of fibrovascular membrane on top and evidence of chronic hemorrhage. Oh, I did have the vessels in here too. I bridged it too much. They're supposed to be here. Good. And that is this case. Are there any questions? Anyone have any questions in the audience about this one? Okay. Can then move on to our next one. This one's a little bit of a mystery to me, so I'll come along the journey with me. So this one is the eye from an 8-year-old female spayed.
Someone asked which,
Oh, yeah.
which fungal agent.
Oh, yeah, great. I should be talking about that. Thank you. The question was which fungal agent we should be considering here, and that is a great question that I totally skimmed over. So in short, I can't provide a specific genus and species for these fungi. For mycotic keratitis, I'd say the classic one we always think about is Aspergillus. However, typically that isn't going to do this 90-degree branching, so I do wonder about a different agent. It could be something that falls under the umbrella of like hyalohhyphomycosis, so fusarium, something like that. But ultimately, it's a little bit of a shrug for me. I'm not quite sure who this is, but I do suspect it's something opportunistic. I don't know if you guys have any other thoughts.
I've stopped bothering to think about it.
I think that is fair. In a lot of these cases, we do offer, there's like a panfungal PCR that we can send out for using the formalin-fixed paraffin embedded tissue from this sample. Typically, we only really recommend that strongly if it's going to have any clinical impact. In this case, it seems like the fungi were excised with the eye, so it may not be really necessarily relevant to actually get the true species of this fungus. But that is something that we can do with the tissue we have with variable success. Some cases we do get false negatives. So what am I doing? Going back to the PowerPoint. Thank you for that question. Okay, this is the eye from an 8-year-old female spayed boxer. And the history we received was this eye had panuveitis, secondary glaucoma, and it looks like they had performed infectious disease testing. They submitted for an Aspergillus antigen test, which was positive. Testing for coccidioidomycosis and cryptococcus were negative. And they specifically said why the aspergillin antigen was positive. Fungal disease didn't fully fit the clinical presentation, so they were concerned maybe about an underlying neoplastic process. They did do chest and abdominal radiographs, which had no significant findings, and ultrasound was also unremarkable. They said this has been going on for less than a month, and they also mentioned that the patient is underweight. So here is a hemisection from that right globe. Cornea is up top, and here's our optic nerve. Optic nerve head maybe is going to be right there. And grossly, we had noted the eye did look a little bit ophthalmic. We said the cornea was cloudy. We noted that the iris, which is right here, over here, and our ciliary body did look pretty heavily pigmented, so it's dark brown and a little bit thick. And then what might also catch your eye is there is this light tan to white wispy material in the anterior vitreous immediately adjacent to the lens. Mhm. All right. Mhm. All right, so taking another little tour at low power. Cornea again at the right. Our posterior segment will be to the left. Cornea itself is pretty unremarkable. I probably won't talk about that much more. Our uveal tract is heavily pigmented, as we saw grossly as well. And there are some areas where it does look like there is some expansion. So the iris just looks maybe a little bit thicker. Over here again, we can see that heavy pigmentation and some areas where there's maybe a little bit of expansion of that ciliary body. As we move back, our choroid's also somewhat heavily pigmented as well. Um, Somewhere in here. Here's our lens. There's a titch of cataractus degeneration in the lens, not really the same as the last one, so I probably won't show much of the lens here. It's not very exciting. And then there is all this material in the vitreous, just posterior to the lens. There are some black Sharpie marks, which we can ignore. What's more important here is just these kind of clusters of what look like cells. There's some basophilia to them. We'll go ahead and look at those more closely. Our optic nerve head is cupped in this particular section, so we do have evidence of glaucoma. And then here's our retina. We can look at that more closely. At least ventrally, it looks like there is pretty severe retinal atrophy, which could be a sequela of glaucoma as well. So first starting, their uveal tract. So that heavy pigmentation, ooh, the camera's gonna hate this. Heavy pigmentation corresponds to all of these melanin-laden round cells within the stroma. They're relatively bland, so they all kind of look very similar and homogeneous. And a lot of them, there's all of this melanin pigment within the cytoplasm. It's hard to make out their nuclei. In areas where we can see the nuclei, it looks like maybe there's spinally stipple chromatin, one very prominent nucleolus. Not much in terms of anisocytosis and anisokaryosis. Again, pretty mild, minimal atypia, and no mitoses seen. So this distribution, the fact that we have some subtle distortion of the uveal tract and this heavy pigmentation, is most suggestive of uveal melanosis, also known as ocular melanosis, which is just a non-neoplastic proliferation of melanocytes within the uveal tract. The Cairn Terrier is a really classic breed that will develop that. In Cairn Terriers, it's usually bilateral, but we can see it in other breeds. Boxers are another overrepresented breed. And it can cause secondary glaucoma due to distortion of the uveal tract, as well as we can see pigment dispersion, and that can kind of clog up the aqueous outflow pathway as well. In dogs other than the Cairn Terrier, this can be a unilateral condition, but it does warrant just monitoring the other eye in case the other eye does also have uveal melanosis. So there's that. And then our other thing to look at is going to be these cells in the vitreous, which is unrelated to uveal melanosis. Here they are. So we have this atypical population of cells. They do look fairly monotypic, so I believe these are all the same population. Sometimes they're kind of rounded up, especially when they're exfoliated from the larger clusters. In some places, they do kind of have a more polygonal appearance. And there's a little bit of variation in their appearance. Sometimes they have these more eccentric nuclei. Sometimes they're a little bit more central, like this guy here. They all have finely stippled chromatin and 1 to 2 pretty prominent nucleoli. There's 2 here. And there are some somewhat freakier cells in here. Let's see. I believe this is where my dot comes in handy, maybe. So in some regions, we have these like pretty large, bizarre nuclei. And there are some mitotic figures in here as well. I think maybe that's what my other dot's trying to show. Maybe not. Yeah, so occasional mitoses too. Just kind of show some other clusters here just to show them off. And they are confined to the vitreous. I don't really see them anywhere else. They don't seem to be infiltrating anything. So these are a little bit enigmatic to me. I don't have a great answer for who these are. Kind of just land on some as I showed them. So some thoughts, they do get a little bit foamy in areas, so I did wonder if these could be macrophages. The nuclei don't quite fit a macrophage. They have these really, really large, pronounced nucleoli. I feel like macrophages usually have slightly more kind of scattered chromatin. They almost look like a chocolate chip cookie to me. In some areas, just the way they're kind of forming structures, I did wonder if these could be epithelial, though again, it doesn't quite fit that. Just a slightly bizarre population. So I hedged a little bit with my diagnosis of these. I just said atypical round polygonal cell proliferation. I did offer IHC for these, so I offered cytokeratin to see if these were epithelial, as well as a CD204 to rule out or in a histiocytic population. They did not take me up on that, so these will remain a mystery for us. But if anyone has any thoughts on these, I'd love to hear it. It's kind of a weird one. And I also mentioned that I was unsure if these were neoplastic. I think there is concern for that, given their appearance, and they're just very, very atypical. I can't quite make these inflammatory. So I did say, given that they're in the vitreous, there's maybe concern this could be a more systemic process. So with the dog being underweight, it might be prudent to stage this patient fully if he hasn't been. I know that they did imaging at least, which was normal. So a little bit of a mystery from this one. All right. I think those are the main things. Otherwise, everything else is just, yeah, consequences of chronic glaucoma. So optic nerve head cupping, and here's our atrophied retina. There it is. So I've taken up a lot of time. I will move to our diagnoses. So yeah, main things being, yeah, this atypical cell proliferation in the vitreous, as well as evidence of uveal or ocular melanosis.
The gross is like classic for COGS.
I know.
So,
It's
yeah.
more pleomorphic than usual.
Yeah,
Yeah,
exactly.
the cell morphology is not, but the gross is just like
Mhm.
classic for canine ocular gliovascular syndrome.
Agreed.
But,
Mhm.
yeah, wow. I remember looking at this one. It's just so.
It's so weird. Yeah. Yeah. I think I'd come in kind of with the bias that maybe this was going to be COGS. And then I'm looking at it, I'm like, I can't.
Yeah.
I feel like I kind of short circuited a little bit looking at the cells, trying to make it COGS because it just doesn't quite look like it. So,
I don't know.
Yeah, right.
Pun.
so if I recall, this was kind of a lengthy comment, which is, yeah, probably frustrating. Frustrating for me as well. It's just a very weird case. Yeah. All right. Like that. I will pass the mic over to Dr. Clemens.
Okay. So next up is a tobacco fish. They're like a little cute, adorable fish. And we have an eye from said fish. This is from a series of necropsies. So this tobacco fish died of unknown causes. Reportedly was about 2 years of age. And so this was pulled. I was pulled at necropsy. It's basically the history that we have and unknown death. So on gross exam, we're actually looking at the front of the intact globe of this little tobacco fish, or intact perhaps in quotes, because we have uncut, at least by us, because we have this giant hole in the front of the eye. It's sort of peripheral or paraxial to peripheral, and then the rest of the cornea here is quite cloudy. You can see the limbus here kind of going into the rest of the animal there. So cornea cloudy, giant hole. Main findings at gross. Right. Maybe we can do a full subgrowth without putting it. Not quite.
You should do that. Put it there.
It's a little eye. So here's a subgrowth of our hemisection of this little fish globe. Here are the edges of our giant hole in the front of the eye. You can see that there's a lot of basophilia at those edges. So it's most likely a real perforation, but we'll take a closer look. Over here we have scleral ossicle, and we have scleral ossicle on this side as well, although it's artifactually kind of folded and peeled on itself. The uvea is supposed to be situated kind of right up here. There should be an iris coming out like here, and like ciliary body like here, but it's not. It's way over here, which is problematic. And it's kind of the same on the other side. There's folded up uvea here, but nothing really up here where it should be. So already we could make a diagnosis of cyclodialysis. Could be artifact, but we'll take a look closer. So dialysis means to separate, and cyclo is our prefix that relates to the ciliary body, so it just means like a torn ciliary body. It's been torn away from its normal anatomic location. We have all of the suprachoroidal fat, which is supposed to be here. We'll zoom in closer on the radium mirabilis, which has a really fun name, and it's just this cool vascular structure that a lot of teleosts have. We have our optic nerve here, which is sort of artifactually fragmented looking. That's probably most of what we can see on subgrowth, I'd say. All right, closer look. So here's one end of our defect again, and the other end in the front of the eye. We zoom in closer on this cornea, a lot of the basophilic stuff is inflammatory cells in the stroma, but some of it is this hyperplastic epithelium, which is sliding over the edge of this defect. Here it is continuing. And then you can see a tiny bit of the epithelium continue onto the back of the cornea too. So we definitely know that this is a real in vivo corneal perforation with epithelial downgrowth into the eye around the edge. If we zoom in really close right at the edge, kind of the deeper aspect, we start to see something fun. We have these little linear guys, maybe kind of branching sometimes, and they're a little bit of a light brown to them. So these are fungal hyphae. More on those later. We can take a look at this area where the iris and ciliary body is peeled away. Here's ciliary body. We can see kind of that double layer still. And there is a little bit of fibrovascular tissue lining the place where it's been lifted away. So we do call this a true in vivo cyclodialysis. There's been a bit of remodeling where that's happened. And right next to this inflamed uvea covered in fibrovascular tissue, there's this beautiful little Marimo moss ball of algae fungal hyphae. So this this is fungal hyphae. Actually, really fungal hyphae. A lot of fish end up with mycetes in their tissues, but this is actually really fungus, and it's also admixed with a ton of bacteria. There's everything, all the things. If we look over here where the scleral ossicle is kind of peeled away, hang on, where are we? There we are. We've got another spray of fungal hyphae kind of coming out of the bone, which has been exposed by when the tissue ripped away from it. And you can kind of like mentally put the scleral ossicle back in place. And when you do, there's like a ton of bacteria lining its surface as well, right here.
That's unusual in terrestrial animals.
I know, to have
Having
both
bacteria. And fungus, yeah.
They're kind of, you think penicillin, right? Like
Right.
fungal hyphae generally tend to downregulate bacterial growth and vice versa. So
At least on the eye.
Yeah.
Referring to the eye.
So in the inside of the globe is also just a chaos of fibrovascular tissue and inflammatory cells and hemorrhage. We've got our lovely nucleated erythrocytes here. And I did promise that we'd take a quick look at radium mirabilis. Look at how pretty it is, this vascular structure in the suprachoroidal space. While we're back here, the sclera just kind of abruptly ends actually here. And there's not much reaction bridging the space, so it could be some sort of like anatomic foramen, but it could also be a rupture back here. And just really quick, the last thing I'll show. There's a cute little osteoclast and a house ship's lacuna in the scleral ossicle. There's a little bit of remodeling of the scleral ossicles. Anyway, so long story short, this is a corneal perforation, probable scleral rupture as well, with a really significant endophthalmitis, keratitis, and it's septic with both fungal hyphae and bacteria inside the eye in spades. So most likely, given that there's cyclodialysis in this case as well, I would be inclined to blame this on trauma. So ocular trauma of some sort. Little fishies can experience trauma from tank mates. Sometimes tank mates don't get along well and can pick at each other, um, or can be traumatized by elements in their environment or things like that. So it can happen sometimes to fishies. Um, but it's also worth warning, or at least keeping in mind, that some of the bacteria and or fungi in this eye could have grown in after like an initial trauma occurred. It's unclear if it's or even after death, so it's unclear what part of it may have been initiating etiology versus something else. But it's a really cool eye to look at for a pathologist anyway. So there's some diagnoses for our tobacco fish. There aren't any questions. I'm actually going to switch over with Gillian, and we're going to do kind of a double feature today, probably to close this out.
Alrighty. Hello, this is Gillian. So, I will be showing the first part of this case. This is an eye from a 15-year-old English bulldog, which I didn't know they made them that old, so I was pretty impressed when I read that. The history we got was the patient has had glaucoma in the left eye since April of 2026. And that means it was present for about 2 months, maybe. It was uncontrolled on various treatments. There was also ulceration of the cornea and concern for an intraocular mass. They also say severe uveitis as well. So the IOP was 57. So we chemisected the eye, and cornea is always at the top. Here's our lens in the center, and here's our retina and optic nerve down here. The cornea is a little bit opaque, so there's probably a little bit of some stuff going on in the cornea. There's this gelatinous goo in the anterior chamber that's a little bit orange, so no doubt there's a little bit of hemorrhage in there. And then what we have is this white tissue that's sort of lining the surface of the iris on both surfaces, so anterior and posterior. And it's also in the iris stroma. So there's something abnormal happening there. The lens is opaque, so that's a cataract. And then the retina is detached, and there's a bit of hemorrhage in the vitreal space. And then I think when we cut it, there was probably liquid in the brown, yeah, we said brown subretinal fluid, which washed out and is on the cutting board at this point. Okay, so those are the main gross features. Now I will show. Let's see. All right, so here's our subgross. So we have the cornea here. We have that stuff that corresponds to the orangish reddish goo that was in the anterior chamber. There it is, looking pretty pink here. Here's the anterior uvea. So here's the iris, and then moving into the ciliary body. And it's a little bit, so most of the iris is very pink, which is consistent with necrosis. We'll look at that at higher mag. But then when you move into the ciliary body and this area, and also sort of moving into the sclera, actually, there's a very basophilic infiltrate, and that is similar over here. So we have some sort of abnormal infiltrate. There's the lens, and then there's our detached retina. So go ahead and jump. So we'll just go right to this part here. So in the ciliary body and in the iris and also in the anterior chamber where I think it is mostly necrotic, we have an abnormal population of cells that should not be here. They are forming these lobules. They have fairly large nuclei, so relatively small amounts of cytoplasm with up to maybe 4 nucleoli, and some of the nuclei are really big, like this magenta one right here. So there's quite a bit of cellular and nuclear atypia here, anisokaryosis and anisocytosis. And as we look around, you can also find a decent number of mitotic figures. I think I counted 17 in 10 fields. Some of the cells, let's hear. So when we have a cell population that is forming lobules like this, we think about an epithelial cell population. And there were some other interesting formations on the other side of this eye that are also pretty suggestive of an epithelial population. So not only are they forming lobules, but they're also forming these sort of trabeculae, and they also are sort of surrounding these lumens in one to several layers that are kind of jumbled, also consistent with an epithelial population and suggestive of a carcinoma. Some of the cells also adopt this kind of phenotype where they have really brightly eosinophilic cytoplasm, which is suggestive of keratinization. And then here we have one that's actually sloughed off into the lumen here. So we have some interesting features here. The sort of neoplastic cells lining lumens is more of a glandular phenotype, but then we have some areas where they're more solid, and then also we have areas of keratinization. The distribution of this neoplastic population in the eye, whereas it's not necessarily in the stroma, although it may have been in the stroma and it led to necrosis, but it is certainly sort of in the spaces or potential spaces of the eye. So this is the ciliary cleft, and this neoplastic population has infiltrated into the ciliary cleft and then into the sclera, and then down into the ciliary body stroma. It's also lining the posterior cornea on this side here. So it's lining surfaces. And whenever we see that in a neoplastic population in the eye, we generally consider this to be a metastatic, a feature of metastatic lesions. So in other words, this is a neoplastic population that originated elsewhere in the body and then has metastasized to the eye. Another possibility for this population is an iridociliary origin. However, most iridociliary tumors that originate from the ciliary body epithelium or the iris epithelium will form a mass either within the ciliary body only or on the surface of the ciliary body. They more often than not will make a mass that actually projects into the eye and sort of displaces the lens. So we don't have that happening in this case either. I'll quickly talk about some of the other lesions in this eye. So we have really significant corneal epithelial cell hyperplasia. Sorry, epithelial hyperplasia. So this is much too thick for normal corneal epithelium. We also have a very disorganized corneal stroma. So this is fibrosis and vascularization. There's a bunch of little blood vessels in here. And then right here is evidence of a previous subepithelial cleft, which has then filled in with fibro sort of plastic tissue, so fibrosis as well. So that's evidence of previous subepithelial cleft. And I think they said that this globe had a corneal ulcer at some point. We obviously have a lot of hemorrhage in the eye here, and then there's some proteinaceous material. The uveal necrosis is a little bit of an unusual lesion. I assume it is because the blood supply was compromised, probably back here in the ciliary body somewhere. And then it led to like this watershed sort of necrosis of the entire anterior uvea, or at least the iris, because that's present on both sides here, where we just have no more remaining viable cells in the iris, except you can see the melanin still, but finding an intact nucleus in here is pretty difficult. So that is good for ischemic necrosis. And you could potentially consider that if this was a metastatic lesion and these cells were arriving via the bloodstream, they may have gotten into the eye and then also led to the occlusion of the blood supply to the anterior uvea and then led to necrosis. There is a little bit of cataractous degeneration, which is the least of this dog's problems. But we've got some liquefaction of the lens fibers. We've got a few more ganglion globules. And then the retina is diffusely detached. And there is, we have hypertrophy, of the RPE cells right here. I've got a little bit of blood in the subretinal space. And then also we have shortening of the photoreceptor inner and outer segments, which are all consistent with pretty chronic retinal detachment. So we have a pretty ugly looking carcinoma in this eye. I'm pretty highly suspicious that it is metastatic. And now I will pass it back. Well, we'll look at my diagnoses real quick and then we'll head over. We'll go to Megan. So very briefly here, poorly differentiated anterior uveal neoplasm, clean margins though, differential diagnosis of metastatic carcinoma. And there was squamous differentiation, which can be seen in various glandular tumors. And now we will pass it back over to Megan.
All right. So this dog, having received the diagnosis in the left eye, went to staging. And with the staging imaging that they did find masses in the liver and lungs, and the patient ended up euthanized. So they did a necropsy examination, and they found multifocal firm pale nodules throughout the lungs, liver, spleen, intestinal mesentery, and they found larger masses in the liver in particular, middle right lobe, it sounds like, and middle of left lung lobe. So they took the larger left lung lobe and middle right liver lobe masses and the remaining eye for us at necropsy and sent it along so that we could take a look at this case and get some follow-up, which we don't always get. So it was really cool that we got this follow-up. So, we now have lung and liver. So liver is up top here. Somebody, not gonna name any names here, already cut into the liver piece they sampled before photographing it. But regardless, this is kind of what the surface of the liver looked like. You can see these multifocal to coalescing tan nodules poking through, and then on cut surface, the same presentation. Note that the middle part of the liver here is very red. Same thing in this slice. The liver is a much more dense parenchymatous organ that the formalin penetrates a lot more slowly than some other organs. So essentially the inside of the liver is a little bit more poorly fixed as compared to the outside. It happens a lot in liver specimens. On the bottom we have the lung, and it's the same sort of deal, multifocal to coalescing, pale tan nodules, and we can see them again on cut section. Okay. It's been a while since I've looked at lung and liver, so bear with me. And we'll do an overview. We'll probably not go into serious detail, shall we say. So here are our sections of lung, and you can see that there are these large, highly cellular masses. They're kind of expansile and compressing the surrounding alveoli and bronchioles. They're pretty darn big. And then not only that, but if you walk away from the main masses, here we go, into the pleura, for example, we've got these subpleural vessels that are multifocally packed with cells. Same thing in this section down here. Not good. And when we look at these masses themselves, there are multifocal to coalescing islands of more purple stuff, which is the cells. And in between, there are these coalescing areas of pink stuff, which is usually going to be necrosis. And it's necrosis, but also there's quite a bit of keratin hither and thither, like in the eye, but more. It's probably the theme of the lungs and the liver, like in the eye, but more. So we do have these cells that are forming coalescing lobules and cords, and they do frequently progress to cells that have this glassy or hyaline, brightly eosinophilic cytoplasm, and then eventually in the centers of some lobules, overtly keratinized material. In some areas, just kind of an interesting feature, maybe there's keratohyalin, maybe melanization. There's something going on here. But it's definitely looking like quite a bit of squamous differentiation is what we're getting here, just like we saw a little bit in the eye, and indeed confirms the favorite diagnosis in the eye initially of a metastatic carcinoma. You can see these neoplastic cells. Where? There we go. All right. We can see these neoplastic cells in sort of subpleural vessels away from the main mass. Interestingly, in the subpleural vessels, they kind of do more of like a coalescing cord type of arrangement, which is a little bit more of what some of the eye cells were doing too. And you can see these neoplastic cells kind of distributing out into surrounding airways, even though overall the nodules can be somewhat kind of well demarcated or expansile. So here's some neoplastic cells kind of heading out into the airways along with neutrophils. And if we look around, maybe sometimes just random cornified debris, which is usually very antigenically stimulating. So it's not good to have it free in the tissue. It makes for a lot of inflammation. Otherwise, it's pretty much just some non-specific stuff. If we migrate out into the lung in general, and I find an area that I prefer, maybe debatable. Like there are areas where they're having more of a party than this, but there's a good amount of pale eosinophilic fluid, and in other areas, maybe more so than this, there's quite a few alveolar macrophages hanging around. So I think there's some real edema going on here and not just post-mortem change, which makes sense because there's giant masses in the lungs. Here we go. Hodgepodge of alveolar macrophages having a party, occasional neoplastic cells, some inflammatory cells, a little bit of blood, etc., etc. Unhappy lungs. If we look at the liver, it's kind of even worse than the lung. We again have a similar neoplastic population forming very large and often kind of expansile nodules. But all of these little foci of purple hither and thither throughout the liver are more neoplastic cells. And they're showing up all over in sinusoids and in vessels. So again, showing quite a metastatic pattern here. Here they are in sinusoids. And here are the big masses, again, showing off that frequent squamous differentiation and keratinization. And the rest of the liver shows some liver things, periportal fibrosis and probable dilated canaliculi with some degree of cholestasis and a bunch of different pigments that I could chase with special stains, but didn't because it's not going to inform our diagnosis right now. So we're being lazy with our liver workup maybe, but
It doesn't matter to the
it
patient.
doesn't matter to the patient, yes, at this point. Or to the patient's people. We have our answer. It is a metastatic carcinoma. Briefly, this is the eye, the other eye, that is, and apart from a little bit of autolysis, it's not really showing much in the way of changes. So it was just the one eye that got affected by metastatic disease, at least per our histologic sections. So we'll throw that tumor back up again while we talk. The final kind of suggestion about what might have happened in this case, I think that it is possible that this tumor may have initially been primary pulmonary, given what they found at necropsy. The lungs can develop primary squamous cell carcinoma. Another possibility for this case, given that it does sometimes maybe do some tubular things, could be adenosquamous carcinoma, which could again be a pulmonary tumor primarily. And then the sort of multifocal distribution in the lung, if it was a primary pulmonary tumor, could be explained by metastasis within the lung, either via the vessels and or the airways. Pieces of tumor can kind of break off and then go somewhere else in the lung via the airways. The other possibility that the lung was also a secondary kind of metastatic site and that there was a primary somewhere else. Most likely, this is not a primary liver tumor. I think the liver was affected by metastatic disease. So they said that they found masses in spleen and mesentery at their necropsy. My guess is those weren't the primary either. And it's possible that especially if you don't have like the resources of a state diagnostic lab, there may be some more occult spots for a primary tumor that could have been hiding on them. Something like oropharynx or like middle ear, like that's locked up in bone, or like somewhere in the intestine if the entire tract isn't run and like gently rinsed or whatever. Or somewhere in the subcutis or the mammaries, like hidden by fat or hair or things like that. So there are possible kind of occult locations for a primary tumor that may have kind of started this, or pulmonary. That is kind of what I would suggest as differentials in terms of where this started. Oh, we do.
A couple questions.
Couple questions. Okay.
I got you. The first one is, was there any history of a previous follicular tumor or dermal tumor in the
Yes, given the the question was, is there a history of any sort of dermal or follicular tumor in this dog? My guess is that's a question because of the maybe keratohyalin granules that we're seeing. So at least none that was reported to us. But we could ask them again. They're curious about this case. So
Second question is, what IHC can be used to differentiate between an adenosquamous pulmonary tumor and a squamous cell carcinoma?
You're asking the wrong person. The question is, what IHC might we be able to use to differentiate between a squamous cell carcinoma and an adenosquamous carcinoma? There are very specific cytokeratins out there that can be used. There's something like TTF or something like that for like primary lung tumors. But ultimately, you're probably asking the wrong person in terms of differentiating between different lung tumors. I've spent many years looking at eyes. I'm very specialized at this point. We'll put it like that. I'm special.
And Dr. Ludwig chimed in, and she thinks that this might be her case. And just at least a bit before the nucleation, and she just wanted to let everyone know there was no known history of dermal masses.
No known history of dermal masses. There you have it. Yeah, I wonder if something was hiding. There can be masses that can be quite occult, or like I said, it could easily be a primary pulmonary tumor. I keep repeating myself. Anyway, any other questions or comments?
Just an appreciation for ocular ongoing systemic duplicabilities.
Yes, sometimes we can look at the rest of the ocular incubatory apparatus. Yes. Okay. We have 5 minutes. I'm gonna shift. There you go.
All right, now I'm back. Okay, 5 minutes to do this cool case. All right, this is an eye from a 6-year-old cat. The history we got was shallow anterior chamber with flat mass-like appearance of the iris involving the nasal hemisphere and extending over the pupillary aperture. Rubiosis iridis with neovascularization extending on the anterior lens capsule with significant caliber blood vessels. 360-degree posterior synechia/dyschorrhea. Pinkish proliferative tissue at the pupil margin laterally. Mature cataract, could not visualize the posterior segment. They say the other eye of this cat has an incipient nuclear cataract, but a normal fundus. They say nothing else about the body of the cat. We said the eye was ophthalmic due to a mass effect. Let's see here. There was a scleral bulge. Ta-da! And there was a mass. So we said tan mass with multifocal pigmented foci. Mass fills the entire anterior chamber. And then there's broad anterior synechia. You can see the relatively normal looking iris leaflet smashed up against the cornea there. And this is the lens and posterior synechia as well. The vitreous contained what we say is a glitter bomb sheen. So you can appreciate all those little glittery bits in there. And this is actually the second half of this eye. I went back and took a picture of the remaining second half after I looked at this slide. So we don't have the optic nerve in this half. But anyway, you can appreciate that. And whenever we see sparkly stuff in the eye that is consistent with chronic hemorrhage, and that is breakdown of red blood cell stuff. All right, so let's, since we are short on time, we'll just jump right to it. So, here's our cornea, here's our mass, there's the lens, here's iris on this side, smashed up against the back of the cornea. So this mass sort of surrounds and carpets the surface of the lens. It also infiltrates into the anterior uvea. So this is iris and ciliary body here. You can see the ciliary body epithelium. And what you might be seeing from low mag here are these islands of pink stuff. And we're going to focus mostly on this right now. Also from low mag, you can start to pick up some significantly large cells, perhaps multinucleated cells. And when we look, so these cells, this is a neoplastic cell infiltrate here. The neoplastic cells are surrounding these sort of trabeculae of fibrillar bright pink stuff. This fibrillar bright pink stuff is consistent with osteoid. And so presumably these neoplastic cells are creating the osteoid. You can see some cells are in lacunae in the osteoid or bone. We did not decalcify this eye. And then you can see some of the cells are multinucleated, and we've got a pretty significant variation in cell and nuclear size as we look around. So where the heck did this neoplastic cell population come from? I just got finished telling you that carpeting equals metastatic. However, in this case, I have a different theory. So our lens is definitely cataractous. You can see relatively normal lens fibers and then liquefied lens fibers here. Also, here's our anterior lens capsule coming along, then all of a sudden it is discontinuous. And as we carry on around here, we're going to look higher mag at this area. So here are some of those neoplastic cells on the outside of the lens capsule. Here's the posterior lens capsule, and we can see neoplastic cells on the interior of the lens capsule. So my theory is that this is a tumor of lens epithelial cell origin associated with lens capsule rupture. And in this case, they happen to be producing osteoids. So this is an osteosarcoma variant of what I think is a post-traumatic ocular sarcoma in cats. They typically begin after the lens capsule ruptures, and you have fibrous metaplasia and the neoplastic transformation of the lens epithelium. And then they migrate outside of that lens capsule and then affect the anterior uvea. They will, given enough time, eventually circumferentially affect the entire globe, which they hadn't quite gotten to the back at this point. As I said, all the sparkly stuff, I'm trying to think of what else I should say about the tumor. The osteosarcoma variant of the post-traumatic sarcoma is one of the rarer variants of it. The chondrosarcoma and the osteosarcoma are quite rare compared to the regular spindle cell variant. And then another variant of the post-traumatic, which we're trying to change that, is the lymphoma variant, but that doesn't come from the lens epithelium. Anyway, this eye has had chronic hemorrhage, so we have a lot of red blood cells here, and all of these sort of needle-like clefts here are due to cholesterol crystals, which occur upon red blood cell breakdown. The actual lipid component of that is washed away in processing of tissue for paraffin embedding. But these clefts, these cholesterol clefts and cholesterol crystals are what give things that glitter bomb sort of appearance. So those are the most important features here. So these tumors affect the eye, and actually I think it did sort of more circumferentially extend around the eye here. Some of that might be hypertrophied RPE cells. So these can metastasize given enough time. They generally occur a long time after ocular trauma. Up to 7 years, or average of 7 years, I think. And so here we go. So feline post-traumatic sarcoma, osteosarcoma variant, clean margins, and then there was lens capsule rupture with hypermature cataract and intralenticular neoplastic cells. Lots of other lesions as well, like chronic hemorrhage. Question? No questions? Okay, cool. Sorry for keeping us over a few minutes. Okay. All right, so thank you for coming and thank you for your attention. And we'll see you again in 2 weeks.
There's an extra comment in there about GTF one. Because it's very small. So one carcinomas, maybe positive and thyroid carcinomas. Yes. Square cell, is more morphologic than organ specific, as squamous differentiation can be seen among a number of epithelial carcinomas. Yes. Thank you. Thanks.